This was a patient, 28-year female, having a history of left upper limb claudication for almost 1 month, having a history of a mild fever off and on. And he was incidentally found to have discrepancy in bilateral upper limbs. The right upper limb BP was around 180 by 110 millimeter of mercury, while the left upper limb was around 130 by 100. So there was a difference of 50 millimeter of mercury between both upper limbs. And for that particular reason, she was taken for a peripheral angiogram. But because she was having autoarthritis, we did coronary angiogram also, just to rule out coronary artery disease. And CHG, coronary angiography, was normal, but on peripheral angiogram, she was found to have critical stenosis in left subclavian artery. There was significant stenosis in thoracic aorta and right renal artery stenosis. Because it was symptomatic because of left subclavian artery stenosis, we did angioplasty of left subclavian artery. And we took 7 French Moulin sheath. We took so many wires, but at last the whisper wire, which could negotiate the lesion. And this was the tight stenosis at the origin of the left subclavian artery. You can see here, and so the wire crossing was very easy in this case. And in the initial part, we dilated with the balloon, but as the wire was pushed further, I came to across a difficult loop which was almost 130 degree. And not only this was having a loop, but apart from having loop, at the middle of the loop, there was a side branch also. So you can see here that every time the wire was going into the side branch. And I started with the BMW wire, then took Whisper filter wire, then tried All-Star wire also with balloon support. But I was not able to cross that lesion. And in this process, the wire could perforate the artery. You can see here. So after so many trials, I thought that let's try with the retrograde approach. Means I took left radial approach and put the right Judkins catheter. And I tried, but again, the same thing was there, that the wire was repeatedly going into the side branch at the loop site. And in the procedure, there was distal to the loop, there was minor dissection also. So it was really very difficult. At this site, it was looking that the wire could have crossed. But as I pushed the wire, no further passes were there. So finally, one suggestion was there that why not to try this technique. So what I did, that the cine was not taken, but I inflated the balloon in the proximal part. Because before that, I did all the maneuvers like abducting the arm, stretching the arm, and all the things were not giving any success. So in this case, the one balloon was taken, it was put proximal to the this loop, inflated. We made a loop of the whisper wire proximal to the this loop, and while pulling the inflated balloon at the same time, I pushed the whisper wire forward. I was really not knowing that whether it was going in the true lumen or false, but it could cross, and finally I tested this, that it was going easily. Then I started with the first I put a smaller 1.5 by 6 balloon, that whether it is having some resistance or not. But fortunately it was going without any resistance, so I thought that it is in the true lumen. Then after giving dilatations with the larger wire, I thought that it might require more support, so I put 5 French Judkins catheter anterogradely across the lesion and exchanged with the Terumo wire, and Terumo wire was taken out by the radial artery to give more support while putting the stent. And then I dilated with the larger sizes of balloon. It was proximally, you can see here that it was a tight stenosis here and here. which was even after giving so many dilatation, it was I was not able to fully open this artery, and this was the after dilatation. This was the result. We put two stents. One was 8 by 150 millimeter and self-expanding balloon, sorry, stent, and this was the second stent which was pushed. So, sorry, this was the final result after, and this was post-stent dilatation was given, and so this was the final result after doing this much of intervention. So this is, I think, there might be so many interventionists who are doing such technique, but I think it is worthwhile to show this case here. Thank you.
Just two questions. What problems do you face when you do an angioplasty for Takayasu arteritis, in an artery? And second thing is, you have put in a very long stent.
Yeah.
And after how many weeks did it occlude? After how many weeks did it occlude?
No. First, the loop was...
No. The first question is, when you do an angioplasty in Takayasu arteritis, what problems do you face as compared to an atherosclerotic?
It is fibrotic lesions, so sometimes it is difficult to, means if you are doing angioplasty, because of a fibrotic lesion, they usually don't expand.
Do you face any problem with the spasms?
Spasm of the artery?
Yeah.
But
Okay, fine, don't worry. And when you put in such a long stents in the arms, did you follow up this patient? After how many weeks did stent occluded?
she came in after 1 month in the follow-up, and he was having normal BP, means there was no discrepancy in both upper limbs. She will come later on also. I will try for the renal artery stenosis because she's having hypertension.
It was a very nice case. The loop technique we use a lot of time, SFA and so forth. But here you had the balloon. Do you think that the inflation of the balloon helped you to keep in a coaxial position with the loop going down the artery? Because usually we don't use the balloon as we're going down. We have a guiding catheter. So what function do you think the inflated balloon had in terms of making your success with the loop technique?
So when we inflated the balloon and we pull it forward, means proximally, possibly it has straightened that particular segment of the artery. Means just inflated the balloon and pulled it back. So possibly the loop was straightened by the...
Mr. Chairman, we are run out of time for this presentation. We'll move on to the next one. Thank you, Dr. Shrimal.